Pattern of discordant growth and adverse neonatal outcomes in twins. Twins gestation, representing approximately 3% of births, are associated with an increased risk of neonatal morbidity and mortality compared with singleton gestation, mainly due to higher rates of preterm birth and fetal growth restriction. In contrast to singletons, adequacy of growth of the twin fetus can be assessed not only in relation to existing reference growth charts, but also through comparison to its co-twin, as reflected by the intertwin size discordance. This is calculated as the difference in the estimated or actual weights of the co-twins divided by the weight of the larger twin. This approach, which takes into consideration the individualized growth potential of the twin pair, may improve the detection of pathological growth restriction of one of the co-twins. Indeed, intertwin size discordance has been reported to be an independent risk factor for pregnancy complications, including preterm birth, stillbirth, and short-term adverse neonatal outcomes. However, most studies use birth weight and not estimated fetal weight for the definition of discordance, with the measurement being taken in a single time point in pregnancy. We hypothesized that different patterns of discordance in twins may be associated with the risk of adverse pregnancy outcome and may be superior to a single point assessment. The aims of the current study were to identify distinct patterns of discordant fetal growth in twin pregnancies and to determine whether these patterns are predictive of adverse pregnancy outcomes. This was a retrospective cohort study of all women with twin pregnancies who delivered in a single center between 2011 to 2020. We included live-born twins delivered in a single tertiary medical center who had at least 2 ultrasound studies for estimated fetal weight during gestation. The following cases were excluded: monochorionic diamniotic twin pregnancies complicated by twin-to-twin transfusion syndrome, monochorionic monoamniotic twin pregnancies, cases with unknown chorionicity, cases complicated by genetic or structural anomalies, fetal reduction of one or both twins, stillbirth of one or both twins before 20 weeks gestation, gestational age at birth less than 20 weeks, and cases with incomplete data. The allocation to one of the different discordance patterns was done using the following 3-step algorithm. If there was no discordance of 10% or above on any of the last 2 exams, the pregnancy was allocated to the no significant discordant pattern. If the discordance was first noticed only after 24 weeks of gestation, we consider it to be a late discordance pattern. In case of discordance first noticed prior to 24 weeks of gestation, women were allocated to either an early progressive discordance or discordance with plateau, depending on whether the discordance kept growing or was stable later in pregnancy, respectively. The study outcomes were preterm birth under 34 and 32 weeks, preeclampsia, birth discordance, the rate of birth weight under 10 centile, and short-term neonatal outcomes. Overall, more than 1,000 women were included in final analysis. Of them, almost 60% had no significant discordance, 2% had early progressive discordance, and the rest had either early discordance with plateau or late discordance. The description of the 4 discordance patterns stratified by chorionicity is presented in the figures. The main difference between the dichorionic and monochorionic twins is that both early discordance patterns were noted much earlier in the monochorionic twins. In addition, while in dichorionic twins, the late discordance pattern was noted at approximately 30 weeks of gestation. In monochorionic twins, it was noted already at 26 weeks. To determine the clinical significance of the patterns described above, we assess the association of each of the patterns with pregnancy and neonatal outcomes using the Note Significant Discordance pattern as referent. Overall, we observed a dose-response relationship between the severity of discordance pattern and adverse outcome. To determine whether the discordance pattern is more informative than the commonly used simple measure of size discordance, we compare the associations described above with the association of fetal size discordance at 32 weeks with adverse outcomes. Fetal size discordance had a similar association with the outcomes of perfect discordance at birth weight under the 10 centile for gestational age to that observed for the discordance pattern. However, it showed no association with preeclampsia and only weak association with preterm birth. In conclusions, we identified 4 distinct discordance growth patterns among twins. Those patterns demonstrate a dose-response relationship with adverse outcomes. It seems that the use of those patterns are more informative than a single measurement of size discordance for adverse perinatal outcome.